Hello, my name is Rob Ty. I'm an associate professor of medicine in the Division of Pulmonary Allergy and Critical Care. And I'm the moderator for today's session. Really privileged to have quite an amazing group of individuals who are here today to talk about aspects of their own research in climate and health. And trying to provide a landscape for thinking about issues that relate to climate and health and why it's a critical need going forward. This is hopefully will be interactive, so we'd love for there to be a discussion. The way we're going to organize the session, I'm going to just have a brief, 2-second overview of some of the issues that relate between climate and health. And then ask my esteemed panelists to talk briefly about, introduce themselves, and then to talk briefly about the work that they've been doing in climate and health. And then what we'll do is after that is have a panel discussion. I'm happy to take questions from the audience. I would actually probably prefer that. But we also have some questions that I can bring up to spark a conversation. The goal here is obviously to facilitate a conversation and thought process between this crowd of people that have been thinking about climate and health and have been already doing some stuff with you all in the audience to bring expertise together, because there's a real important need to mobilize campus to start to think about these issues broadly and to figure out where we can work together. As one person phrased, climate and health is the grandmother of all multidisciplinary challenges. So it is a real big issue that we really need to think collaboratively across campus to really be impactful in this space. So with that, I will just go through a couple of my intro slides, and then we'll sort of have each of the individual talk about themselves. Briefly, before I do that, I just want to sort of superficially introduce our panel speakers. So over here we have Mercedes Bravo, who is an assistant research professor of global health in the Duke Global Health Institute. We have Nishad Jayasundara, who is the Julie Plant Granger Assistant Professor of Global Environmental Health in the Nicholas School and the Duke Global Health Institute. On the end, we have Denise Neveu, did I get it right? Yeah, there we go. Who is an associate professor in orthopedic surgery and was recently in 2023-2024 the Duke Climate and Sustainability Teaching Fellow. In the middle, we have Bill Pan, who is a professor of global environmental health in the Nicholas School and the Duke Global Health Institute. And then also in the middle, we have Dr. Catherine Stanton, who's a professor of emergency medicine and neurosurgery and global health in the School of Medicine in the Duke Global Health Institute. So with that, why do we care? So I don't think it's any sort of rare understanding with, of course, the fact that today is a particularly cold day, so it sort of does defeat the purpose. But actually it is relevant, because I think what we also need to appreciate is that we're going to have extremes. We're seeing extremes on both ends of the temperature spectrum, right? So there are good reasons why we have these prolonged periods of cold snaps, which didn't exist in the same direction as we used to. And that has to do with changes in our environment that are occurring in our weather patterns that really facilitate these really longer snaps of weather at both ends. But the vast majority of this is that our climate continues to warm, and it's warming at a rate that we probably don't completely understand, particularly when we start to think about ocean temperatures. And I know that that's starting to get more understanding in the media, but there's really something that's going off of the normal scale. And so in the sort of bottom left, what you see here is below that is a spaghetti plot of different temperatures. And if you look at data, for most often, data should sort of gradually increase, but something's really gone off in the oceans. And the oceans are one of our major sinks for temperature. And so this is probably telling us something about how this climate is changing and changing rapidly. And that warming drives a lot of disasters that we see in the media, whether it's wildfires, whether it's periods of drought, or it's periods of large water. And we've seen that certainly in the state here. And all of that leads to a variety of worsening health human impacts. And this is a figure from the CDC that, if you're interested, you can look at in more detail, that sort of talks about the relationship between climate-related events, how that leads to specific things that happen in the environment, and what are the impacts on human health in those things. There's a very broad way of trying to say that this is our generational crisis, right? So our generation, both people in this room and our kids, are going to be dealing with this and trying to understand, how do we manage the impacts. So with that, what I would like to start with, and this depends on the order of how the slides are in here, which is a bit of an adventure, is I think this is Mercedes. And so Mercedes is going to introduce herself and talk a little bit about her research.
Thanks, Rob. Okay, so yes, as Dr. Tai said, I am an assistant research professor in the Global Health Institute. I joined Duke just a few years ago in 2021, and I'm an environmental epidemiologist by training. So a lot of my work to date has focused on air pollution, although I've also looked at metals, PFAS, and extreme temperatures. So today I'm going to talk about two specific studies. These are pretty specific examples, and then I'm going to sort of bring these together with an overarching call to action. So the first study is about air pollution, and it's about disparities in exposure, right? So this is a study that was published in AJE in 2022, and it looks at where is air quality improving, and I'm going to focus on PM 2.5 just to be brief today. So we look at where is air quality improving in North Carolina over a period of about 15 years. And so these are the time trends in PM 2.5 over 15 years in North Carolina, right? So this shows us basically that air pollution is going down everywhere. See how all those numbers at the bottom are negative, right? Indigo to yellow, they're all negative numbers. That's great. It means PM 2.5 is decreasing, and PM 2.5 is harmful to our health. So it's great news that it's declining everywhere, and this is a great public health win. But one of the things I was interested in understanding is not just spatially where is PM 2.5 declining, but also demographically where is PM 2.5 declining by larger versus smaller amounts, right? So to do that, I fit these fancy Bayesian spatiotemporal models and found some really interesting results. So one demographic characteristic that I looked at was urbanicity, right? More urban versus less urban communities. Another demographic characteristic that I looked at was segregation. So that is communities that are predominantly non-Hispanic Black or non-Hispanic Black and Hispanic versus predominantly white communities. And when we compare high segregation versus high urbanicity communities, we see that they start at similar levels of PM 2.5, right? But the slopes are different here. So even though we start at similar levels, the high segregation communities just saw an average decline in PM 2.5 over time. Meanwhile, the high urbanicity communities, which started again at a higher than average concentration, but similar to the high segregation communities, they experienced a larger than average decline over time. So essentially, over time, even though PM 2.5 declined everywhere for everyone, we actually saw a widening in the disparity of PM 2.5 exposure if we were to look at high segregation versus high urbanicity communities. There's another way that I wanted to look at this as well, though. So here's a comparison of high segregation versus low segregation communities, right? So in a typical sort of, unfortunately typical environmental injustice story, high segregation communities had, at the beginning of the study period, higher than average PM 2.5 levels. Low segregation communities had just average PM 2.5 levels. And both of those communities saw just the average decline in PM 2.5 over time. So what we see at the beginning of the study period is a disparity in PM 2.5. And by the end of the study period, although PM 2.5 has declined everywhere for everyone, we have actually done nothing to address this disparity. It has persisted. So the next study I want to talk about is a study that's currently in submission. This is also based in North Carolina, statewide, and looks at heat waves and preterm birth over a period of 5 years. Please do not cite or share because this is just in submission, hopefully soon to be published. So here I was looking at heat waves in the last week or 2 weeks of pregnancy and hazard, or we can think about this as likelihood or risk of preterm birth. So what I found is that if you have 2, 3, or 4 consecutive days of heat exposure in your last week of pregnancy, you have an increased hazard of preterm birth. So these are the hazard ratios and their accompanying 95% confidence intervals in parentheses. So because these are all greater than 1 and the confidence intervals don't overlap with 1, we conclude that heat exposure in the final week of pregnancy is associated with increased likelihood or increased hazard of preterm birth. This is across the whole population of women who gave birth in North Carolina between 2011 and 2016. When I break these down, though, by race ethnicity, a really troubling pattern emerges in which we don't actually see any associations between heat exposure and preterm birth for non-Hispanic white women. All of the associations are for Hispanic women and non-Hispanic Black women. They're slightly higher for Hispanic women compared to non-Hispanic Black women, but not statistically different. This unfortunately tracks with a lot of the literature that's out there, right, with non-Hispanic Black women, and in some cases, Hispanic women having higher risk of preterm birth. Another way that I could look at this, and as you can see, I've tried to parallel this disparities in effect study with the disparities in exposure study by looking at segregation or race ethnicity and then urbanicity in both studies, is that even though we see, so in urbanicity, we see that there is an association between heat exposure in the last week of pregnancy and hazard of preterm birth across urban, suburban, and rural communities. But these hazards are higher in rural and suburban communities as opposed to urban communities. Not necessarily statistically different, but still an interesting finding. Particularly interesting in the context of urban heat islands, where you might actually expect urban areas to be hotter than rural areas, right? But what we're seeing here is that at a given level of heat exposure, the signal, right, is larger in rural, followed by suburban, followed by urban areas. And I think that's the last of my animations. But just to sort of pull this all together, I see this really as sort of a call to center issues of health equity, social, environmental, and climate justice in our research so that we produce research and policy informed by that research that addresses and ameliorates existing health disparities instead of exacerbating and perpetuating existing health disparities. Thank you.
Awesome. And the next one is.
Thank you, Rob. Good morning, everyone. Thank you for being here and interested in this topic. So my name is Nishad Jayasundara. I'm an assistant professor in the Nicholas School of the Environment with a joint appointment in the School of Medicine and also at Duke Global Health Institute, which means a lot of the work we do focuses issues around areas around the world that is not necessarily based out of North Carolina, but there's a lot of application of this work that turns back to the state we live in. And I think one thing we think a lot about is how climate change is a disease risk multiplier, which increases the risk of chronic diseases. And that was really well highlighted by Dr. Brow a second ago. And that's a common theme around the work that we are doing. And one area that I think a lot about is who is most vulnerable. And again, that was highlighted earlier, is that the communities that are most vulnerable to climate change and the health outcomes that are preceding that are really the communities that did the least to contribute to this problem. And those are the communities that also have the least amount of resources to tackle this problem. So focusing on those communities can teach us a lot about what's going on, what's changing, and how are they responding, and also think about low-cost solutions and interventions that we can come up with. And that's sort of the crux of the work that we are trying to do in the context of how especially heat exposure and some of the other exposures associated with climate change is contributing to this development of a peculiar form of kidney disease. I think we all are aware of what a kidney is, and as the Time magazine put it, chronic kidney disease is poised to become the black lung of climate change. I think that's a little bit exaggerated, but they have a point in that article, which is to really say that kidneys, just the way that kidney physiology work and how it works in the context of heat exposure, really increases the tissue's susceptibility to heat stress and also subsequent dehydration that can come with heat stress. But also just the way that our kidneys work, there's an oxygen gradient within the kidney that facilitates this transfer of ions that's happening in the kidney. You're always constantly filtering blood through your kidneys, and to facilitate that, your kidneys work in a way that there's some gradients that are set up, and these gradients are affected from heat exposure directly. So there are several different ways in which heat exposure can directly affect our kidney health, and that sort of led this sort of popular magazine article. But also, a number of studies have supported that claim, and really, that claim has come to quote unquote fruition, which is probably not the best word to use here, in these communities where there is a rise in kidney diseases in around the world. And these are some of the communities that I've been privileged to work in, and I've highlighted some of those in this map here. And you can see many of these regions that are highlighted are in the tropics. And what we are seeing is an emergence of chronic kidney diseases, especially in tropical farming communities or communities that are warming at a faster rate than some of the other regions. Even within the same country, you see this difference where exposure to heat stress, but also exposure to other types of environmental contaminants or other types of environmental perturbations like agrochemicals are contributing to this manifestation of this disease. So we call it chronic kidney disease of non-traditional origins or chronic kidney disease of unknown etiology. It's called unknown partly because we don't exactly know how this disease is manifesting, but the two factors that are associated with it are exposures, again, heat, and then also agrochemicals. And we are seeing this disease manifesting in Mesoamerica, in South Asia, now some data emerging in Southeast Asia, also seeing data coming from parts of Africa, but also here in North Carolina as well. So we're beginning to see this emergence of increasing prevalence, especially among those who work in strenuous labor conditions, in outdoor conditions in the tropics. And there's a lot we can learn from studying this disease, and we are trying to do many sort of different types of work to try and understand the precise drivers of this disease outcome, including a focus on children who are already showing signs of declining kidney health in some of these impacted communities. A lot of our work is based out of Sri Lanka, and Mercedes has been a great collaborator in developing that work, especially the work around pediatric kidney health and trying to understand how heat stress modifies kidney health in these children that we are focusing on, and then how exposure to some of the other contaminants in their communities may exacerbate that heat-induced kidney injuries that we are measuring in these kids. So lots of things to learn from, and also lots of challenges we are dealing with, which I think we'll get to in a little bit. But I also want to leave with this message where I think climate change discussions are often quite defeating, and we can often leave a room feeling like there is no hope left. And one thing that's really kept me going in this work is the communities that we get to work with and the resilience that these communities have shown in dealing with these multitude of environmental exposures where they often didn't really have much to do with. And seeing that resilience, and also seeing their willingness to learn science and their openness to contribute to the research that we want to do and learn from that science to make changes in their communities has been really inspiring. And I think that's one way to think about how do we move this work forward as communities. Thank you.
All right, now it's Catherine's turn.
Good morning. As introduced, I'm Catherine Staten. So I'm an emergency medicine physician from the Department of Emergency Medicine and an implementation scientist. I work through here. About 25% of my time I'm in the emergency department, so don't come visit me there. Come see me at the Global Health Institute instead. We work both globally and locally. I got into climate change through injuries. Globally, one of the most acute things that can happen is you can fall and break an ankle and you need to get to the hospital. When we get to the hospital, we call 911. It's not bad. If you're in a rural area of North Carolina, it's not as good. If you're in the middle of nowhere in Brazil and you need to take a river that no longer exists, even worse. And so as we think about access to care, it starts us to understand what's happening in the setting of these disasters that are occurring far, far more frequently, and how that impact is impacting us, not only us as a community here in North Carolina, given what's happened in Western North Carolina, but then globally for our Indigenous populations and the populations who are most at risk, the most vulnerable populations. So as we started to think about this in this terms of access to care, whatever that care might be, we started to pull together data that we had. And now that was environmental data, climate disaster data, disaster being heat, hurricane, drought, snow, wind, cold. It was freezing. And then overlay that data with health data. How are people accessing health systems? Who needs to access health systems and is not accessing health systems? How can we get that data? We started out here in the United States using EMS data, so 911 calls. That's only if 911 gets a phone call. Globally, we are having to reach out to our populations and our communities and saying, tell us when you're not calling, because most populations and vulnerable populations don't reach out. So as we start to overlay this data, we're starting to see the chief complaints that are happening, that are responding and in response to the disasters that are happening, whether that is Western North Carolina or now this dry river in Brazil. And as you can see, this data is giving us an understanding of an increase in heat that's happening over the last 30 years. We're seeing these health-related disasters amongst each of these components increasing and increasing differentially depending on where you live. But once we do that, we have to come up with microplans. What are microplans? How do we solve the issue? As an implementation scientist, I can't just study it and say, oh, that's a problem. We want to fix it and evaluate if that problem can be solved. So these microplans come from the community because they tell us what they need. So this is where health system resiliency comes in. First, we need communities that are resilient. What does that mean? A community that knows what they need. We need help to build those communities that are resilient. Some great examples. Recently, I talked to Orange County here in North Carolina, and they're building community centers that are climate change resiliency centers where they have conversations with their population about if the power goes out or if the electricity goes out, what do you need? What do you need most? What do you need first? What do you need more long-term for these longer disasters? Those conversations can infuse into our process to be able to create these microplans where the health system can step in and how they are needed to step in depending on the time period. So cross collaborations from the Global Health Institute, Emergency Medicine, the State Office of Emergency Medicine Services, Nicholas School, and then our partners in Brazil. We've started these conversations with both indigenous populations as well as local populations and understanding where are the pressure points, where are the resilience possibilities. And once we're trying to understand what that is, then we can move backwards of creating both resilient communities, but then also resilient and, it has to be said, nimble health systems so that we can respond, right? Think about what happened in Western North Carolina. People still don't have what they need. People still don't have electricity, power, water. Some of the first things that were asked of, this was amazing, they asked for shipments of alcohol because their underlying addiction to alcohol, if that stops, they're going to have severe, overwhelming number of patients in withdrawal who is going to take up the health system beds. We had to create new hospitals in the region. So really understanding what are the chief complaints going to be? How do we prepare supply lines? How do we organize human resources? How do we create communication pathways? It might be different for every climate disaster, but each one can have a formula, have an understanding of the things that could be involved and bring it together. And without understanding or having these collaborations with communities, it'll be far harder. So part of our work has been amazing to be able to learn from the community what is needed, where it's needed. Many of these things we had no idea, but has been able to be overlaid on the data science and implementation science that we're working, and excited to see some of the new microplanning that's coming out of it. Thank you.
Thanks, Catherine.
I wrote a little bit because I don't trust myself to stay to 5 minutes. So I'm Denise Neveu. It's an honor to join this esteemed panel. I teach in the Occupational Therapy Doctorate Program here at Duke. If you don't know, occupations are everyday activities that people do as individuals, as families, as communities in the community, to live, to occupy time, to bring meaning and purpose to life. So OT, or occupational therapy, is the therapeutic use of everyday occupations with persons, groups, or populations for the purpose of enhancing or enabling participation in the community. So I've been an OT faculty member for some years, and my research focused on disability rights movements in West Africa, specifically Ghana. I started wanting to work on climate change and ecology some years ago, wondering why My field focused largely on promoting access to built and social environments, which of course is very important solidarity work in fighting the oppression of people with disabilities, but seemed to have little to say on deeper levels about human environment relationships, environmental justice, or how human occupations were collectively outstripping our natural environment's ability to support life. And I thought it had something to do with the way that we taught about health as a separate subject from environmental science. My field has yet to engage substantively with the planetary health framework, which is built on the simple premise that we need a healthy planet to ensure the health of all people. What I've posted in the middle of the slide is the planetary health education model, which is developed to apply to all educational fields and really challenges the way that my field, until recently, has been conceptualizing human environmental and social relations and how they relate to health. In 2022, I started hearing about efforts underway in the medical and nursing schools here at Duke to teach about climate change. So I was really excited, and I reached out to collaborate. With funding from AHEAD, which is an institute here at Duke that focuses on improving medical education and health education more broadly, we put together and launched a 9-month, 2-semester pilot interprofessional course on climate change and health for health professionals. So the curriculum, the modules are listed there. Faculty in this course were from Nicholas School of the Environment, Physical Therapy, School of Nursing, School of Medicine, and even the Campbell School of Pharmacy down the road in Durham. So it was a tremendous collaboration. We started out with 38 students, no credit, totally voluntary. So 21 finished the course. And based on pre-post data, those who participated were already, interested in climate change. They were already concerned about climate change. They were taking climate protective behaviors and actions in their own lives. But what they said they learned in our course was that healthcare systems are directly implicated in climate change due to the massive use of resources and supplies, as well as waste generated, and as we've been hearing, often ill-prepared for the catastrophic weather events generated by climate change. So they started to think about, what are our responsibilities additionally to patient care? Students said they didn't feel empowered to take action in their workplaces, so much more likely to take protective actions at home than at work, and that's consistent with the research. We're now working on a Duke Coursera course so that this work can be shared much more broadly. And the unit I'm writing right now is about how do you, as a health professional, get activated and find others to collaborate with you for systems change. So the complexity of the climate crisis and the enormity of what we need to do to mitigate, adapt, and build resilience, as you've been hearing, is significant and can be so overwhelming that an understandable, if unhelpful, response is to avoid this reality altogether, throw up one's hands, feel helpless. But one thing that gives me hope is that I am far from alone in my concerns and in my very humble actions. The extent of educational efforts on the parts of my colleagues here at Duke, and also my colleagues here in North Carolina and the South, as well as nationally and internationally, is truly heartening. So in healthcare fields alone, all those logos that you see on the left side of the slide, all of that stuff is constantly happening. They're constantly emailing me and offering me webinars and resources, and that's overwhelming. But that's another topic. So extensive efforts are underway, and Duke University is part of the Planetary Health Alliance, which produced the framework that you see here. That's a global consortium of universities and other institutions, and they're developing really useful materials, including curricular materials. So I find that very heartening. So things are happening. Extensive efforts are underway, led partly by healthcare practitioners like me. We're trying to educate each other. We're trying to educate future practitioners. We're trying to educate policymakers and the public about climate disruption and planetary health. So there's lots of work to do. We're in good company. Everyone's talents and persistence are needed, including everybody in this room. And as marine biologist Ayanna Elizabeth Johnson reminds us, it's really about identifying the intersection between what work needs doing what you know how to do and what you love doing. Our human occupations are overwhelming the world. It is true, but we can employ them wisely to save it. So thank you, and I look forward to our discussion.
Thank you. And last but not least, we have Bill.
So thanks everybody for the invitation to come. I did not make any slides. I apologize. I took a nice vacation this holiday. So my name is Bill Pan. I'm a professor in the Nicholas School of Environment with a joint appointment in DGHI. My training is actually, I'm a biostatistician by training from UNC down the road. I've been working on climate and health research since my dissertation. I work mostly in the Amazon. But just to tell you how I conduct climate and health work with my team. So essentially, what we first do whenever we're doing any kind of climate and health work, we try to distinguish whether or not there's a seasonal pattern that we can detect. What is climate change in the seasonal pattern? And what is a climate extreme? And then we say, how does human behavior, how does animal behavior, how does biodiversity, how do other environmental determinants respond to those climate characteristics? And then whether or not we're studying malaria, dengue, leishmaniasis, whatever we're doing, we're trying to look at a pathogen and say, how is that pathogen related to climate itself, independently of any of these other things? But then also, how do humans, animals, biodiversity, et cetera, impact transmission probabilities of that disease? Fundamentally, that's how we approach all of our research. We do it in a very engaged way. So we work very closely with ministries of health. We work very closely with policy and community stakeholders. And we try, very similar to what Catherine was saying, we try to create solutions at community levels, especially in the Amazon, where even if policy exists, there's no governance. They don't have a way to protect themselves. So we try to work with communities themselves to build resilience. So the three things I just want to talk about really fast on the things that we do. The first one, which is our main one that we do on climate and health, we've actually now launched something called the Amazon Research Consortium. There's a LinkedIn page if you want to go on LinkedIn. We actually have a website on Duke where we show all of our dashboards. These are these climate health dashboards. But really what the Amazon Research Consortium is, or the ARC, I found out that there's another ARC acronym at Duke, the Academic Research Council. I just discovered this yesterday, but I'm assuming they were first. But this is really a place where we're trying to get together the universities, the communities, the governments that we work with to come to a place where they can look at their own data, because we've created a data harmonization process across 4 of the 7 Amazon countries. So it's Colombia, Ecuador, Peru, Brazil, where we've combined climate data for the last now 27 years, all of the health surveillance data, population data, infrastructure, rivers, land use cover, everything under one data harmonized space. And it works very well in the sense that it allows us to ask questions for the health system on how climate or environmental change is impacting disease processes. And we focus right now mostly on malaria. We're expanding to dengue. But we also have expanded into, we now work in Panama. So we've created the same system in Panama, and we've done it in Honduras. And actually, I said Colombia, but Colombia actually comes online this year because we just got a grant from the USA to expand it. But what that system essentially does is that it allows, produces a forecast of malaria. We actually call it a nowcast and a forecast, because surveillance in most countries is not real time. It comes with a data lag. So we try to produce estimates of incidents at a community level from the time that the surveillance system last was updated, which often is 6 weeks ago, up until today. And then we produce a forecast. We used to only do it 3 months in advance, but now we do it a full year in advance. And we do that because half of our team are climate scientists who have really cool methods to allow us to extend our forecasts in ways that we couldn't have done otherwise. So Sheneng Hu has this really neat way of expanding El Nino forecasts, for example. And this actually allows us to produce forecasts in Colombia 36 months in advance for malaria in certain regions of Colombia. Now, El Nino does not predict everything very well. It has really poor predictability in parts of the Amazon. But on the Pacific coast of Colombia, it's almost the number one predictor of malaria. It's shockingly good. But anyway, we produce these forecasts. We have it on our dashboard. We update it each month. We use the Duke Compute Cluster to do this. We have AI models. We've got fancy Bayesian machine learning models. We've actually gotten kicked off of the main compute cluster because we're using too much space. So we're on this partition space now. But we provide these PDFs to ministries of health and regional health directorates so that they can see how each individual district is doing in terms of their malaria trajectories and which variables are actually predicting their malaria trajectories. And then we tried that, like that implementation side is actually quite hard. And communicating that risk is quite hard. And I won't say in all countries they're using our data. Panama and Honduras actually are really excited about it, and they're actually changing some of the things that they're doing. Although I just found out just before this meeting, because I had a meeting with Panama this morning at 9, that they are closing down their vector control unit in the Darien, which is a really unfortunate thing because they're heading an extended rainy season and they're going to have massive malaria there. But nonetheless, they are taking into account some of the things that we're predicting into their decision making, which is great. But the speed of that is probably not as good as I would like to, but we're working on it. The second thing I just wanted to talk about was we work a lot on migration and how people are migrating internationally and also being involved in occupational labor migration, which is essentially return migration. And we look at this in terms of how it changes vector ecology and also changes disease processes. It's not necessarily climate driven, but climate is usually what is driving the timing of migration. We see a lot of seasonal patterns to movement, and we use those seasonal patterns of movement to try to predict when diseases will go up and down, or when we might want to increase surveillance to predict whether or not a new pathogen or a new genetic strain of malaria might be needed to be evaluated. The third thing I'll mention is a new study we just started last September, and it's really looking at just by luck, I got a veterinarian student she's a vet who's a master's student in global health. She was in the military, and we've been doing a lot of work on looking at lead exposure and different diseases in deer and in humans, mostly related to lead. We expanded this because we started working with the U.S. Fish and Wildlife Service, and I learned, because I don't usually work in the United States, that Mattamuskeet, which is on the eastern North Carolina, is a major area for Canadian geese and swan to spend their winters. And they've had these massive die-offs for the past couple of years because of lead exposure. So now what we're doing, because of this massive avian influenza outbreak globally, so we're working with U.S. Fish and Wildlife Service to collect samples of ducks and swans. We're looking at chemical exposures and from taking feathers, and they're doing a bunch of viral testing, looking at different coronaviruses, but primarily bird flu. And we're using something from the Audubon Society and the Nature Conservancy to track how those migration patterns of birds are going and whether or not they are going through patches of, say, environmental degradation. Do they go through high areas of air pollution? Because you can look at, using climate models, you can actually look at air pollution at different levels of the atmosphere and whether or not those exposures relate to environmental stressors or stressors for those birds that affect their immune systems. The immunology piece is being done by University of Colorado, where I'm not an immunologist, so I can't even explain what they actually do, but they do some kind of cytokine stuff, and I'll just say that. But they have real good measures of understanding how well a bird's or bat's immune system is functioning, and they can relate it specifically to an environmental trigger. And so what we're adding onto that is really, how are they getting that exposure? Is it because of their migration patterns through some kind of environmental degraded area, or is it just because they're landing in Mattamuskeet, which tends to happen to have a lot of lead, and maybe they have a lot of lead exposure there? That's it. Happy to have the discussion. And back to Rob.
So as you can see, there's a variety of people doing a variety of amazing work in a variety of different areas. And one of the things that I would say to echo some of what's being said is yes, I agree. There's a tendency to talk about climate and be depressed. But I think there's also an opportunity to really feel hopeful about the requirement for us to all start to interact, which I think is a major thing from an academic side. And I will say, as somebody who spent a lot of time over the last couple of months wandering around campus meeting people, is that it's only made me more hopeful about our ability to approach complex problems and to do that in an academic environment, but also the connection that this allows us to build with our communities and the communities that we care about, and the need for that. And I think that's, I'm actually going to take, I'll take the first question, but I'd also encourage people who have thoughts or questions that they want to ask to please raise your hand, and we'll certainly pass around the microphone. But clearly there's a sense amongst all of you all of talking about community. Be that either the community of health professionals, the community that you deal with in different parts of the world, and or the disparities that exist within communities and how we've taken care of that. In some ways it can start to feel a little overwhelming, right? Because then, when you start to talk about, and every time somebody talks about, oh, we need community something, I'm a basic scientist at heart, so I'm outside of the community realm. How do we think about, developing community, and how do we think about also figuring out how we can leverage the communities that we interact with in a way that is not duplicative, but actually is something that actually the sum is greater than the individual parts? And so that's open to everybody. I didn't give this as a preconceived question. Does anybody want to take that as a stab, or is that too much?
I'll say
Yes.
Go first.
Thank you, Rob. And I'll just quickly say that I would flip the question in that I don't think it's us leveraging the community. I think it's that the communities can leverage us. I think we have a big role to play in that we can either be siloed and really focus on getting the X amount of publications out, or we could come together as a community and say, what can we do to solve some of these problems, especially in communities or groups of people, parts of the world that don't really have the resources to do. So I think it's our availability that can be leveraged by the community that I think we could put forward. How to do that, I'm happy to chime in, but I don't want to hog the microphone.
I think for me, my way is to sort of get out there and volunteer in my local community so that I start to know who people are and they start to know who I am, and then the conversations can begin from there. In the occupational therapy program, we have students work in small groups with community partners to do quality improvement studies. So the questions are usually pretty small, but it's something that our partners want to know about the services they're providing to the populations that they serve. And it gives our students an opportunity to see a whole different part of the world, people who love conservation or Duke Campus Farm or any, family caregivers and what they're struggling with. So it's a wonderful exposure. And the last thing I wanted to say is I know that a new Duke Community Engagement Center will be online soon. I actually visited their website the other day because their list of community engagement principles, 5 principles, which don't ask me to name all 5, but I know humility and an asset-based approach, are 2 really important parts. They're a wonderful guide for anything that we do in the community.
I would echo everything that was just said and add very simple words: relationships, because it's the foundation of any of these partnerships and equitable partnerships. Not only the humility, but empowerment, empowering partners to have a voice and to tell us what is needed. Flexibility to do what's needed, right? Like a shipment of alcohol versus a shipment of goods, like what is needed, and we'll do that flexibility. And then asking the question, who's not at the table and how do we bring them to the table? Because our communities are only as diverse and our solutions are only as good as our diverse communities. So we always have to push to improve the diversity and make sure that our most vulnerable populations are represented.
I don't disagree with what they said, but I took your question differently.
Please.
I thought you meant how do you build a climate health community at Duke? I don't know if that's what you meant. Because
Being quite broad about it.
I think, having this symposium, having something like the Climate and Health Centers of Excellence, LOI, from Burroughs Wellcome be out as a competition among the communities at Duke puts us inherently at competition with each other. But I think what you guys are saying about how to build community, we have to listen to those words and say, this is what we need to build a community at Duke. And we need to be open to collaborate. We need to be open to working with people who might have different perspectives on how to conduct the exact same science that we're doing. But it's really hard because, even at this table, we've got 4 or 5 different institutes in Duke, at Duke represented. We have different cultures within each schools. We have different cultures across the institutes. And it makes it hard to collaborate. But I think that since we don't have a center of climate and health research, I think we really need one, because we need a place where we can all go and share ideas, share best practices, and then share the resources that we've already created, so that if people want to join the space, they don't have to do the 10 years of struggle that we've already been doing. And they can just jump right on the train and we can get to solutions as fast as possible.
Can I follow up question with you, Bill?
Yeah.
In your data issues with the Duke Compute clusters, what do you see as the needs there in terms of building that community for climate and health with Duke's data availability?
You mean making the data available or running the cluster?
With its compute power that you need, and then the availability of data for everybody to get in the same space that you're talking about. Is that a component of what you're talking about?
It can be. I think the compute cluster is a great resource. We use it a lot. I think our problem is that we've been using probably too much of it. And I think if everybody did what we did, I think we would we'd have a resource issue with the compute cluster. I think now that what our solution that we've been given is going on these partitions. The problem with running partitions, if we send a job to the compute cluster and it's on a one partition, and then the owner of that computer needs to use it, our job gets canceled. And we won't know it gets canceled until we go back and check and say, oh, it's got canceled. We got to run it again. And, it takes a couple of days to run. But maybe an investment into a primary cluster so that you don't have to be partitioned out would be a good thing. That would prevent us, for example, from having to be canceled out of a job.
Do you see that as a component of this sort of center you're talking about, though? It would.
So not everything requires AI to do climate health research, right? So you don't need to do fancy computing work to do the work. There's a lot more basic science that's needed to understand the relationship between climate characteristics and health outcomes that don't require the compute cluster. That's just one piece that we work with. None of the things with the bird flu, for example, or the migration requires anything with AI or anything with the compute cluster. And I don't know if you guys use a compute cluster, but
I would say one of the issues that I've run into, not necessarily with the Duke compute cluster, because I don't know, but other clusters, is their FSMA compliance. So if you're going to move health data onto a cluster, it has to be extremely secure in a way that if you're going to move publicly available data onto a cluster, it doesn't. And so there are a lot of issues around that with computing clusters where you can't do analysis with individual level or PII data. It's a major issue in climate and health research.
So I totally agree with you, Bill. I just want to say that up front is that the challenge on campus and maybe this is a way that we affect change is that this kind of multidisciplinary work really is going to force, if Duke wants to really do it in a serious way, it's going to force us to have to do things differently than we've done it in the past. And like all things that start, you start somewhere and you keep pushing along the lines of trying to break down the individual barriers that exist across campus, and to make sure that when people are coming to you or any of the rest of the group in this panel, that there's an understanding of the communal nature of what we're up to, and to try to figure out what are best practices rather than having everybody reinvent the wheel. Because I'm the first one that would say that if you're doing something that I've been doing for the last 5 years in basic science, like, please come to me. I will give you the protocol. I don't care. Like, I'd just rather have you not spend the next 5 years doing the same things that we've screwed up. And so I do think that there's an onus on that, and how that looks on campus, I think, is still to be determined. But I am hopeful along those lines that the intent of the people who've been involved thus far really have at heart what you're thinking about, which is trying to figure out the best ways that we can all collaborate together. So that I wanted to make sure I give a chance for somebody in the audience if there is a question that you have, or otherwise I can keep going along with mine. So Hayden's in the back. I don't know if we can ask him, or he can shout.
Good morning, everyone. I'm Hayden Bosworth. I'm in population health science. Thanks to everybody for your presentations. Really exciting. I was hoping somebody would talk about training and education, and maybe the conversation we were just having could link to that I think that there's certain competencies our students need, and perhaps maybe that's a way to another way for us to come together and work collaboratively. And so I don't know if others have some thoughts on that, what those skill sets may be. I hear community engagement may be there, implementation science, obviously, that's my favorite place. But as we think about training and education, what do you feel would be the important skill sets for the next 5 years for our students? Of course, I think 5-10 years, things may change, but for the next 5 years, what would you all recommend, what those competencies and skills that we need to ensure our students have? Thanks.
So I'm happy to pass this along, but I will take something that I know Toddy talks a lot about is trying to create among our trainees at all levels sort of a base level of ability to converse in a climate language. And I do think that we need to incorporate that in the training that occurs on a scientific level. Because one of the things that we certainly, I think, have to combat is the sort of negative connotation of climate, and also the sort of sense of futility that I think exists out in the community. And so only way we can do that is by trying to provide a voice that's more consistent, and that there's a language that our trainees understand, and sort of a basic knowledge base. I don't know if anybody had another comment.
I'll just say my two easiest skills I think everybody needs: climate literacy. That's number one. I think that's lacking across all disciplines. Number two, if you're doing climate and health, you need an introduction to epidemiology. And you need to understand disease processes, study designs, how to, measure causality or attributable risk, how to test that. We have those courses at Duke. I think any other skills you need really depends on the path of the student. Like if they're in Pratt versus Nicholas versus global health, policy, whatever, they're going to have a different set of skills they need to be effective in their careers. But everybody needs to understand, what is climate change and climate science? What is epidemiology?
The only one I would add is team-based science. This is something that is newer in our world, right? It was very individual. And the more and more and more we do this, I think we're going to have to grow new ways of doing team-based science and growing a system that supports team-based science better than we currently have across our schools.
I'll quickly add that I think Bass Connections has been a great avenue for us to do this type of work that's been proposed. And I think that's actually provided a platform for many undergrads at Duke to really be engaged in team science, but also be engaged in climate and environmental change driven health outcomes. Where I do see large gaps is really in the graduate training, where we really push our graduate students to focus on one little thing and go as deep as possible. And that's sort of the foundation of grad education. So how do we change that, I think, has been a major sort of point that's been bugging me. And how do we change that in my lab setting? How do we change that at a programmatic setting? And I think there are a lot of opportunities to do that, potentially through short courses, potentially through field engaged research opportunities for grad students to take 3 months off. Obviously, your advisor is not going to like that because they're funding your time. So there's a lot of different sort of subtle changes that can happen. I think that if there's right amount of funding provided, that I think graduate students can really be engaged in some of the multidisciplinary work while still maintaining the core focus of their thesis.
Okay, so I'll speak to educating practitioners, and absolutely, I support the idea that background in epidemiology is really important. It was lacking in my own education, so I'm trying to catch up now. If you're not going to be engaging in epidemiological science yourself, still understanding the power of exposures to shape health, lacking in a lot of our preparation for at least OTs and PTs, I'd say. Also, we need to develop tools to assess, better tools to assess social determinants of health and environmental determinants of health, and build that into our basic assessments in practice. Skills for climate responsive care. And then finally, advocacy and systems change is necessary. And as health professionals, we're not only clinicians, we have a lot of other roles and we need to step up.
I think as an epidemiologist by training, it's probably easy to predict this, but I wholeheartedly endorse the call for training in epidemiology. And I think I in particular worry about sort of quantitative literacy, especially with the advent and rise of AI, because there's increasingly resistance, I think, among learners, to learn some of the foundations, because there's AI and they can just essentially now chat GPT or Claude, or basically type it into Google. But I counter that with, if you don't learn your basic math, then when AI tells you that 2 + 2 is 5, you won't know any better if you didn't learn your basic math, right? So I think the epidemiology and sort of understanding how, especially in the climate space, statistics are going to be used to misrepresent data or misrepresent findings, because there is going to be spin, because it is politicized. And so that sort of understanding statistics, that how to lie with statistics or how to lie with maps is going to be really critical. And then also, just to second something else that was said, is the social and structural drivers of health. I think there's all these invisible structures in our society, or largely invisible, at least to the majority, right? That really underpin health, right? And underpin, I think, as you saw in my work, exposure, and then also susceptibility to a given level of exposure. And I don't think that's widely acknowledged especially in US, where we have this very individualistic, everybody has an even playing field, and that's just not true. Thanks.
Agreed. I might, as a basic scientist, I might say that I won't ever become an epidemiologist, right, but I do think that there is sort of figuring out what is the sort of base level of knowledge that you need to be able to understand as a person in science, so that I can interact effectively with somebody like yourself, or figuring out how do we develop the teams so that the team includes people that can speak up and say, okay, wait a second. Why, if you're going to do that experiment, why are you doing that experiment? Because that doesn't help me address my epidemiologic question. And so really thinking about how do we develop those teams, and or the events and infrastructure like today, where there are people who are speaking across the spectrum of what they do, so that you're not left in your own silo of saying, like, I only do cell work and the cells just do this. But that work also includes some understanding of sort of where that might need to go, and vice versa, right? So that there may be a question that comes up in epidemiology that needs some sort of basic understanding, so that it actually can inform policy decision that might be painful to make, right? So that it's saying something along those lines. I think the second thing I wanted to raise, because I think Denise started with this, and I may come back to you a bit, is, I mean, I think as a health practitioner, there you have your 15-minute visit or less, and so when you're starting to have to think about how you prioritize the various things that you're going to actually talk about with an individual patient, and I think this is even true from a science perspective, because most of us have the attention span of about 2 minutes, maybe. I think 10 minutes is what we actually say, but it's really something short. And for those of us that actually work on things, we realize that executive summaries get read more than the actual work and or the abstract. So how do we think about sort of that in the context of sort of how do you prioritize things?
Yeah, well, it's interesting because I think that physicians and even maybe physicians have been the strongest voices in the climate and health space. That's what I see when I attend my many webinars. It's doctors, right? And actually, occupational therapists, physical therapists, and nurses generally spend a lot more time with patients than doctors do. So we actually have wonderful opportunities to have these conversations alongside whatever our clients are dealing with. So that's part of my answer. And then I think it's also about thinking deeper and asking more general questions about whatever the chief complaint is that a person brings in. I guess those would be my two answers.
I would say being opportunistic is that the person is there for a reason. They are coming to you, have them in front of you. If you don't say something, you're going to miss that opportunity. So finding the links that you have to either social determinants of health that are impacting their ability to be well, or risk that they have that they might not even know about. It gives you an opportunity for education. And that 4 or 5 minutes that I might have with a patient, if they're able to talk, I'd rather do that or tell them their diagnosis. And we have to teach that because that's not taught in our medical education. And it needs to be focused on the fact that while we have 5 minutes, that 5 minutes is much better suited for education and prevention down the road, or preparation for hopefully not a next time, but a next time.
Are there any other questions from the audience? Yeah, go please.
I'm Ben Killen from University of Communications and Marketing, and we have really a fascinating job at this juncture of working across, the climate space, working across the research space to push that, and Duke's community involvement. All three of those have really gained I think the board and the president and everybody's like punish those things, which is great as they come together. And it's fascinating listening to a group like this talk about that community connection and that, okay, how do we talk to a patient versus how do we talk to our colleagues versus how do we talk to a room full of people with different levels of understanding. And I guess my question is, how do we continue to humanize, these slides, right? These batch of information. How do we take events like this and make them more accessible? Because this is the first climate. I mean, I know it's the first time they've done it in a specific way, but I've been here a long time off and on and have never come to one of these because I'm like, all right, if it's going to be up here, this is not where I'm working. What are the ways that you guys can not dumb down your science, but like you're talking about the patient relationship, continue to figure out how we broaden the community message?
Oh, sorry. Okay, I'll do a.
And then it's how can we as communicators help you guys? The other part is how can we as communicators at the university and around help you guys do that? That's great.
So one experience I recently had was I was invited to be a speaker at the American Association of Journalists, and was really given very specific instructions on how to present this data in a way that the journalists can understand. So they can now change that message in a way that's more amenable to a broader community. And that was a really good experience. And I think that's something perhaps the communications office can do, is to work with a group of researchers on campus and really provide the training to say that kind of messaging could be provided this way. And I really benefited from being a speaker there, just the amount of information I got on how to change your message to that. So that would be a helpful event if you can do something like that.
Your question just reminded me of a funny story, because I had a postdoc a couple of years ago, and I had him give a presentation to the Ecuador Ministry of Health, and he was describing our forecasting system. And what he said was, we have a posterior probability that predicts the probability that the current estimate of malaria exceeds your determined outbreak threshold. And man, you should have been there. Like, nobody understood what he said. I think I might have been the only person that understood what he said. And I'm like, wow, these guys who are policymakers do not understand what he's saying. So we took many steps back to figure out, how do we communicate that, okay, you have a 75% chance that malaria in the next 3 months will exceed some threshold that's high, that you've defined as high. And there's a thing called FuseNet, which is the famine early warning system that works in Africa. Now it's expanding around the world. They've existed since the 80s. And what they do is they have red, yellow, green. And they said, if a country is classified as red, your risk is high for malnutrition. If it's yellow, it's a warning. If it's green, you're going to be okay. And that's how they do it. They don't provide any probabilities, nothing. Policymakers love that. And when we when we pitched that to the Panama Ministry of Health, like last year, they said, oh yeah, we want that. Okay, that just means that all of the models that we produced really are coming down to 3 colors. Great. But that's the way they take it. Like, that's probably the best way to get them to respond. Anyway, that's all I was.
Yeah, I love the idea of language, right? Because we all speak a different language. I remember a story that you were telling us when you were doing your initial sort of interviews out in Eastern North Carolina, and you just kept talking about climate change, and everybody said, we don't have a problem with that. And then we asked, well, what about storms? Oh, we have a problem with that, right? And so we, as scientists, as researchers, as physicians, as practitioners, we have our own language that we have to throw out the window, and we have to sit in our communities and hear the language they use. There's a great training program out of the University of Global Health Equity, where the students literally live with their community. They are in the community to learn the language. And it's an extreme example of being able to do community medicine by learning that language. And once you understand what the population uses as language, then you've more internalized that and you can communicate that risk much better. We don't have that integrated into our medical system because we are not a public health system. We are a treatment system, right? That's how we're set up as medicine. And we have to think from the other perspective. It's one of the benefits of having people from your community be your practitioners because they speak the language, right? They understand the challenges and the adversities that is faced and the problems that are there. So we have to switch how we educate to infuse back into the community or pull from our community to be practitioners. We have to sit in that community to learn the language if we don't know it already. And then we have to have our empowered community talk to us about what this language means to them so we know what language to use and not use, because it will continue sort of the political challenge that's there. And how can people help? There are people who do this all the time, right? There are people who do community outreach that make these connections, that make these networks, that teach others how to speak. Oh, I need help with that, right? I do, all of my trainees do, everybody I see every day. I'm giving bad news. I need to know how they hear it. If I don't know how you hear it, I don't know how to give it. And we've never been classically trained in this. I just saw family receive it the wrong way. And I'm like, ooh, I'm not doing that, right? That's literally how we learn. And so we need to sort of bring back the art of communication all over again to sort of build back up these communication relationships so that we can have our communities lead us.
That's good.
Sure, please.
So I'm in surgical sciences and I have a very unique role where we have like 25 active labs in our division and I'm tasked with kind of helping form relationships between like the different labs. So it's been interesting to hear everyone speak here. One of the things that has come across, and we also have a climate health initiative within our division too, is that there are different sets of information, data that is available that already exists, right? So there are groups that are collecting information. And as I was listening to the question before, I was just trying to think out loud, like maybe an opportunity exists in trying to bring like a lay perspective to these existing data sets where people across the field understand, well, what is X data set, like the seeds health, right? What are they trying to accomplish? There's NIEHS has some, right? So if different groups have access or understand the data sets, I'm wondering if that is a way to engage the community, maybe having case studies and understanding what types of questions can be asked. And so I just wanted to bring that up as maybe a train of thought. And I also wanted to thank you guys for putting the World Cafe together a couple months back, because that had begun the discussion. But I was just wondering, there's already so much information out there. What are strategies where we can bring together that information and make it accessible?
So I'll make a plug. Feel free to email me. Part of my spring is spent working on, at least within the School of Medicine, on a website to try to pull some of the information together, at least in terms of the various activities, and could include data sets that people are or people that want to be contacted. So I know that the Office of Climate Sustainability has also been working on this immense sort of connective board of sort of where everybody is. So I encourage you to reach out to Blake, and he can be angry with me for offering him up. But that's so I do agree. I think there's a lot of energy and a lot of enthusiasm, a lot of initiatives, a lot of things that people are pushing forward. So it's really an exciting time, but it's also a potential time where a lot of people are overlapping their activities and not leveraging them appropriately. So, all right, with that, we're at 11:15. So I'm always a believer in ending on time. So thank you all for being here. Thank you for the panelists, and thank you for inviting us to speak.